Hello, my name is Leon Menezes. I'm a consultant radiologist and a nuclear medicine physician at the Institute of Nuclear Medicine at UCL and here in the Barts Heart Centre. This series of talks from the British Nuclear Cardiology Society we've recorded is to give you the basic grounding in nuclear cardiology, the applications, the technology and the evidence. We hope you find them interesting and useful.
So hello again, my name's Dr. Paul Scully. I'm one of the cardiology registrars at Guy's and St Thomas's, and in this next instalment of our Introduction to Nuclear Cardiology course, I'm going to talk to you about the role of nuclear imaging in the diagnosis and workup of patients with possible cardiac amyloidosis. Amyloidosis in general is a multi-system disorder characterised by the extracellular deposition of abnormally folded protein fibrils. Now, these protein fibrils can build up within particular organs in the body, resulting in organ dysfunction. The types that interest us as cardiologists and that involve the heart particularly are transthyretin, or ATTR, and primary light chain, or AL amyloid. Now, transthyretin itself is a protein normally produced in the liver and responsible for the transport of thyroxine and retinol, hence the name. There are over 130 pathogenic mutations to the TTR gene, many of which can result in varying degrees of peripheral and autonomic neuropathy, as well as some degree of cardiac involvement. Quite how prevalent the cardiac involvement is very much depends on the particular mutation that the patient may have. Now, you can still develop transthyretin-related cardiomyopathy without a genetic mutation, and these patients are said to have wild-type transthyretin-related cardiomyopathy, or wild-type TTR, which used to be known as senile cardiac amyloidosis. And it's important to realise that this is particularly common, and we're beginning to realise just how common now that we no longer have to biopsy everybody to make this diagnosis, and that patients are living longer, and there are novel therapies which are promoting the detection of this condition. In fact, we know from work done by Tan Scannon and colleagues back in 2008 that around about 1 in 4 patients aged 85 and over will have some degree of wild-type TTR deposits within their heart at autopsy. Now, moving on to primary light chain, or AL amyloid, we know this carries a particularly poor prognosis of around about a 70% mortality within 2 years of diagnosis. And it can be associated with either an underlying multiple myeloma, a B-cell malignancy, or indeed an indolent lymphoma. However, most commonly, the underlying plasma cell dyscrasia would be considered a monoclonal gammopathy of undetermined significance, or MGUS, if it were not for the related amyloid deposition that you're seeing. Now, we know that the most common clinical features in AL amyloid tend to be nephrotic syndrome with or without renal failure, congestive heart failure, sensory motor and or peripheral neuropathy, as well as hepatomegaly. Macroglossia is pathognomonic of AL amyloidosis, however, is not always present, and around about a quarter of patients have dominant symptomatic cardiac involvement at diagnosis, which is one of the key drivers for the poor prognosis in these patients. I've already briefly touched on how common we're beginning to find this disease actually is, but it's just important to reiterate that somewhere between 1 in 7 and 1 in 8 of the HFpEF population will have this as the underlying etiology for their heart failure. Now, a similar proportion of the elderly, and by elderly I mean over 75, AS population who have been referred for TAVI will also have concomitant cardiac amyloid undiagnosed unless you look for it. And if looking for it has become even more important now that there are novel therapies available. AL amyloid therapy revolves around chemotherapy plus or minus stem cell transplantation, guided and driven very much by our haematology colleagues. TTR-related cardiomyopathy previously has had very little therapy, unfortunately, only really managing symptoms by carefully managing fluid balance, fluid restriction, daily weights, frusemide as needed for symptoms, with little role, unfortunately, for prognostic heart failure therapy, with ACE inhibitors generally poorly tolerated, as were beta blockers. But I'm glad to say that landscape is changing and changing very rapidly at the moment, with potential novel therapies coming through the pipeline. One example of this is what you can see here on the right, which is tafamidis, which is a TTR tetramer stabilizing agent, which these results were published back in 2018, showed that over a 30-month follow-up period, there was a reduction in mortality from 43% in the control arm to 30% in those treated with tafamidis, and this was in 441 patients, all with TTR-related cardiomyopathy. There was also a reduction in the decline in 6-minute walk test and quality of life. It's important to realise that this is a TTR stabilising agent, so we're not looking at removing the already deposited TTR misfolded protein, we're looking at it stabilising it where it is. But moving on and talking about actually trying to remove this deposited TTR protein, there are small interfering RNA therapies such as patisiran, which is coming through from Alnylam. You can see the data there on the right hand side. They looked at 126 patients with a median follow-up of 18.7 months and showed that there was overall a reduction in the frequency of adverse events, which was a composite of all-cause hospitalisation and mortality. They also showed a reduction in BNP, LV wall thickness, improved GLS and stroke volume over the follow-up period. Another potential novel therapy is inotersen, which is an antisense oligonucleotide, which has shown great promise and showed over a 79% median reduction in plasma TTR levels, with a reduction in LV mass, improvement in 6-minute walk test, stabilisation of BNP, LV ejection fraction and strain at 3 years. And that's some of the Dasgupta data, which is an investigator-led trial. The larger neuro-TTR trial, which was looking at patients with hereditary ATTR, and particularly looking at the sub-study of 108 patients with the cardiomyopathy within that, they showed similar improvements in quality of life to the rest of the study, but unfortunately no change in the echo parameters that Dasgupta and colleagues in the investigator-led trial did, and I mentioned there. So how do we work these patients up? Well, the first thing they get is they get an ECG when they come in, and what you can see here is these sort of low voltages in the limb leads here. But unfortunately, that's not particularly sensitive or indeed specific to cardiac AL or indeed cardiac TTR amyloid. You then go ahead and you get these patients an echo, but unfortunately the echo findings, although can be quite classical when seen, they can also be very non-specific, and here you're looking for some degree of left ventricular hypertrophy, impairment of longitudinal function, biatrial dilatation, possibly a small pericardial effusion. You may find some RVH as well, but it becomes difficult because other conditions can mimic this. Hypertension, for example, aortic stenosis can also. And I would challenge anybody to look at those 4 images and tell me which of those is cardiac amyloid. And so how do you then go ahead and work these patients up? Well, you can obviously consider a cardiac MRI if needed, but there is a key role here for nuclear imaging. And I'm going to talk to you about not such a new technique. And so this was a letter to the Lancet in 1977, where they wrote about 2 patients who showed uptake of technetium-99M diphosphonate within their hearts, and in such patients cardiac amyloidosis should be considered. So we knew about this in 1997, but unfortunately it's taken us until colleagues in Italy in 2005, so Perugini and colleagues, looked at only small numbers, 5 patients with ATTR and 10 patients with AL, echo as the reference standard in these patients, and looked at bone scintigraphy, or particularly DPD scintigraphy in these patients, and found that all of the patients with TTR had some degree of cardiac uptake on DPD, and in fact none of the patients with AL had any degree of cardiac uptake, and hopefully you can see that there. What they then did was invite some of these patients back, and in fact 11 of these patients came back for MDP, which you can see is the bottom row there on that picture. And MDP was the bone scintigraphy tracer that we normally use, looking, for example, for bone metastases. And what they showed was that actually there was cardiac tracer uptake in these TTR patients using DPD, but there wasn't in MDP. So that paper, what they hypothesized was that DPD was quite sensitive and specific for TTR-related cardiomyopathy. And they actually came up with a scoring system based on their findings, where they would grade from 0 up to 3, and this is the Perugini grading system, which is purely a visual scoring system, where 0 is negative, and you can see no cardiac uptake there on the left-hand side, but a lot of bone uptake looking like a classical bone scan. And then 1 to 3 being progressively more and more positive, with progressively increasing cardiac uptake and suppressed or sort of masked, if you like, bone uptake, to the point that a grade 3 looks really like a heart with just some soft tissue uptake and no longer the skeleton. And so this was the scoring system coined by Perugini and colleagues in 2005, and subsequent work, which I'll talk through in a second, by Gilmore and colleagues, which was multi-centre fantastic work, which was published in 2016, showed that this was incredibly sensitive for cardiac TTR, as Perugini and colleagues had hypothesised nearly 15 years earlier. However, there was low-grade uptake classically in AL, so it was not particularly specific for TTR. And I'll show you the data now. So here's a breakdown of the DPD scan findings in the 374 patients who had endomyocardial biopsy confirmed cardiac amyloid. And you can see the endomyocardial biopsy findings on the left-hand side. And I'd just like to highlight a couple of key points here, which is that of the 162 patients with cardiac TTR deposits on endomyocardial biopsy, only one had a negative DPD scan. And when they went back to look at this, they felt that actually the deposits that they were seeing were so scanty on the endomyocardial biopsy and they went back and looked at the corresponding echo images and everything else, that actually it was of doubtful clinical significance in this one DPD negative case. The other one just to draw your attention to, which I think is an important point to bear in mind, is that there was one DPD very positive grade 3 scan that had no cardiac amyloid on endomyocardial biopsy. And actually what they did is they also went back in this case and had a look, and the echo was very classical for cardiac amyloid, and there was no question regarding the positivity of the DPD scan. And so actually what they felt was this was a falsely negative endomyocardial biopsy. And remember, this gold standard, in inverted commas, diagnostic tool for cardiac amyloid is still not perfect and is prone to sampling error. And what I also wanted to highlight is in the cardiac AL population, you can see that around about or just over 50% of patients had some degree of a positive scan, albeit the majority, 60% of those with a positive scan, were a grade 1, so low grade positivity. There are still 9 patients there who have a grade 2 or 3 DPD scan, despite having cardiac AL. So this is where we're not talking, it's not particularly specific to cardiac TTR, and that's a very, very important point. This is part of the same article by the same group, but it's a fantastic flow sheet for the sort of diagnostic workup for patients with suspected cardiac amyloid, where based on the findings of their DPD scan or their HMDP scan, which is what's used in France, or the PYP scan, which is what's used in the US, you can then combine that with serum immunofixation, urine immunofixation, and the results of serum-free light chains, and essentially perform the non-invasive diagnosis of TTR cardiac amyloid. And I'll just draw your attention to that right-hand side column, where the combination of a grade 2 or 3 DPD, HMDP, or PYP scan combined with no plasma cell dyscrasia on serum immunofixation, urine immunofixation, and serum-free light chains gives you the diagnosis of cardiac TTR amyloid. And then depending on the TTR genotyping result, this will either be wild type or variant, and there's no need for an endomyocardial biopsy in these patients. If you get any other permutation of DPD, HMDP, or PYP scan result, or indeed you find evidence of a plasma cell dyscrasia, then unfortunately you will still need a tissue diagnosis or histological confirmation, plus or minus cardiac MRI, to sort of help you confirm or refute the diagnosis. And this is this exact same flowchart has been copied into these recent expert consensus guidelines, which were published only in 2019 and are available online. So let's just talk through a couple of few nice examples here. So 62-year-old man, recent onset breathlessness, and having been diagnosed with HOCM in the past, has asymmetrical septal hypertrophy on an echo and cardiac MRI with no late gadolinium enhancement and a normal coronary angiogram. So some sensible soul sends him for a DPD scan. And now just talking you through sort of the protocol a little bit. So patients arrive for the scan, they get an injection of DPD, around about 700 megabecs of DPD, which is a sort of effective dose of about 4 millisieverts, give or take. And then we were initially, we've moved away from doing this, but we were initially doing an early planar image, which you do sort of immediately after injection. So you actually inject them on the table and then you take the planar image. And those are the images you can see on the left-hand side. And the reason you have two of them is you have an anterior and posterior image. And then what you do is you send the patient away and they come back about 3 hours later and you perform the late images. And this is what Perugini and colleagues back in 2015 were grading. And what you're looking for here on this scan is any cardiac uptake at all, that combined with any suppression of long bone uptake. And if you look very carefully at this bone scan, you can see there is no cardiac uptake here at all. So this is a negative scan. Don't forget, however, I know it's easy as cardiologists just to be looking at the heart, but don't forget you've got the rest of the bone scan to look at here. For the very astute of you, on the posterior late image, so the far right image, you will see on the end of the 10th rib posteriorly, you can see there's a bit of fibrodysplasia there. So don't forget to look at the rest of the scan. You may miss bone metastases or a range of other things. You do look at the rest of the scan. What you're looking at here now is the fused SPECT CT image, which you can use to look at the heart closely and confirm whether or not there really is any cardiac uptake. And hopefully, as you can see it coming past there, there really was no cardiac uptake at all. So that's a grade 0 negative DPD, but you can see the fibrodysplasia there coming in as well. So another example, this is an 80-year-old gentleman, known atrial fibrillation. It's got a cardiac MRI that's suspicious for cardiac amyloid, which is not an uncommon source of referrals, and they're asking for a DPD scan to look at this in further detail. And again, early images on the left-hand side, you often see cardiac uptake on early images. That's really blood pool rather than genuine myocardial uptake. But if you look at the late images here on the right-hand side, the anterior and posterior images, you can clearly see there is cardiac uptake. It's stronger than the adjacent ribs, so by definition we're looking at either a grade 2 or 3. But if you look posteriorly, you can probably reasonably easily count the ribs and the vertebra, and so I would say this is more a 2 than a 3, whereas in a 3 you tend to find it very difficult to count the ribs and the vertebra. You can see that it's difficult to see the humerus on each side and the femur on each side, and therefore there is some long bone suppression as well. Looking at the SPECT CT again now to confirm, or as we say, refute the diagnosis, but here you can see clearly this is lighting up very, very nicely, and this is one of the many reasons I enjoy nuclear cardiology. You don't have to squint and decide whether it's positive or not. This is lighting up very clearly like a Christmas tree, and this is a very positive scan. And they're just the sort of still images to show you in the same patient. So another example, 85-year-old gentleman, known atrial fibrillation with anterolateral T-wave inversion on an ECG, moderate asymmetrical septal hypertrophy, some mid-wall scar on MRI. Question is this HOCM or is this something else? And again, you've got the early images on the left-hand side. You can clearly see the blood pool on the anterior early image on the far left. You really can't say that's cardiac uptake. You need to be looking at the 3-hour late images, which is the 2 on the right-hand side. And if you look here, and hopefully I can convince you with the eye of faith, there is possibly a subtle cardiac silhouette there, best seen on the anterior image, which is that sort of middle late image that you can see there. But that's why we've got the SPECT CT to have a look at it in more detail, and hopefully it's whipping past there, but hopefully you can see perhaps that lateral wall has a little bit of cardiac uptake, but rather than slow it down, I'll show you the still here, and you can see that it's really more on the short axis image, perhaps the inferior lateral wall. You can see there is some cardiac uptake, so this is probably a subtle grade 1. It's not greater than the adjacent ribs or adjacent bones, and there's very little long bone suppression, so this is a grade 1, a Perugini grade 1. So unfortunately for Leon and I, who've spent many hours sweating over whether this is a sort of subtle grade 2 or a sort of grade 1 scan, actually work produced by the National Amyloidosis Centre in 2017 showed very clearly, and this was in 377 patients with wild-type TTR cardiac amyloid, that actually it didn't matter whether you were grade 1, 2 or 3, all that mattered prognostically speaking was whether you were positive or not, and this was a median follow-up of over 30 months, and this perhaps shouldn't be wholly unsurprising in that we are categorizing these patients very arbitrarily based on only 3 grades of positivity in what is a complex multi-system condition. And so perhaps this reflects the sort of crudeness, if you like, of the scoring system rather than actually that it's not prognostically significant. So perhaps if we can quantify this myocardial uptake a little bit better, we will find that this becomes prognostically significant. And this is interestingly what they do in the US, where they use pyrophosphate, so PYP scintigraphy, which is akin to DPD but subtly different in other ways, and ways that we're only really beginning to fully appreciate. So Boccari and colleagues in 2013 used a sort of heart to contralateral ratio where they draw a region of interest over the heart and a region of interest over the contralateral lung, and found that a heart to contralateral ratio of over 1.5 was remarkably sensitive, around about 97% sensitive and 100% specific for TTR cardiac amyloid. And you can see that on the graph on the right hand side, and this was in around about 45 patients that they had. Subsequent multi-center US work in 2016 actually took things a little bit further, and in 121 patients with TTR-related cardiomyopathy, they found that a heart to contralateral ratio of 1.6 or more was associated with a worse prognosis, with a hazard ratio of 3.9 over a 5-year follow-up period. So it seems that actually, if you are able to quantify this myocardial uptake, you can find information that both potentially could help you differentiate between TTR-related cardiac uptake and AL, and that may also prove prognostic, which is seemingly what's coming out in some of the US data. It's very important to still rule out AL cardiac amyloid with the appropriate serum immunofixation, urine immunofixation, and serum free light chains, because you do still see cardiac uptake in AL. The other point to make, as you can see from the images on the left-hand side, is generally in PYP scintigraphy in the US, they tend to do planar imaging only of the chest, and you don't see the same whole body images. They may often do SPECT imaging as well, but that's not in every centre. And work that we've actually done, Leon and I, at the Barts Heart Centre, which hopefully will be coming out shortly in JACC Cardiovascular Imaging, has been looking at means of quantifying actually DPD scintigraphy using sort of SPECT-CT SUV quantification software. And actually we found that it seems to do very, very well, but you'll have to read the paper, I'm afraid, when it comes out for any more information. So just moving away from DPD scintigraphy now, just a couple of brief slides on some of the other nuclear imaging modalities available in amyloidosis. So this is SAP scintigraphy, which was actually the sort of PhD work of Professor Hawkins at the National Amyloidosis Centre, where you radiolabel serum amyloid P with iodine, or 1,2,3 iodine, which has a half-life around about 13 hours. And what you do is you inject around about 200 megabecquerels and you image these patients about 24 hours after injection. The effective dose is around about 4.5 millisieverts. And this binds all types of amyloid. Unfortunately, we don't see any cardiac uptake. And the thought process is this 127 kilodalton SAP molecule can't pass through the non-fenestrated endothelium of the myocardium. It also doesn't provide a visualization of gut uptake or nervous system uptake or indeed skin uptake, but is very good at picking up amyloid deposits within the liver, indeed even before liver function tests are deranged. Kidneys, spleen, adrenals, and sometimes bone marrow uptake can be identified. And actually bone marrow uptake is actually quite specific for AL amyloidosis. However, differentiating the type of amyloid using SAP scintigraphy alone can be very, very challenging, as there is a lot of overlap between the types. But what you can see here is a nice example of a patient 6 months after treatment for AL amyloid. There's been a profound reduction in liver uptake as well as bone marrow uptake on the 6-month SAP scan. So it can have a role in sequential imaging and follow-up of response to therapy. So this is just making that point that I made earlier, that there is quite a range of organ involvement. You can see in SAP scintigraphy quite a lot of overlap depending on the type of amyloid you are looking at. And so it's not particularly helpful in differentiating the types. And the top left-hand corner is a sort of control case that you can see. And then there's 5 different patterns there of AA amyloid uptake, ranging from kidney only to spleen and kidney to spleen, kidney and liver uptake. And on the bottom row, you can see 3 patterns of AL uptake, with the bottom left showing really only joint involvement, and then the middle there showing spleen and liver, and then the bottom right showing spleen, liver, and bone marrow uptake. Finally, just touching on the role PET imaging can have in the diagnosis and workup of patients with cardiac amyloidosis. And now this is a great area of interest at the moment in the literature. Unfortunately, the numbers really for most of the studies are only small. And there are a range of different PET tracers, so ranging from carbon-11 labelled Pittsburgh compound B, which requires an on-site cyclotron, to fluoride labels florbetapir, florbutan, and flumetamol. Now you can see that generally speaking these have higher uptake, and you can see the graph there for florbutan generally have higher uptake for AL as opposed to TTR. So it's almost, if you like, the sort of converse of DPD and in bone scintigraphy, as we've previously discussed. Also of interest, a paper published recently in February this year using Pittsburgh compound B in 41 patients with AL showed a reasonable correlation with the burden of cardiac AL on histology, and that actually the degree of uptake seen seemed to correlate with outcome, and by outcome I mean all-cause death, heart transplantation and acute decompensated heart failure over a median follow-up of about 423 days. The numbers are still small, and there really were only 24 events in that group, but actually this is an area of great interest, and I would expect we'd see further studies coming out in due course. So just in conclusion, and to round up, cardiac amyloidosis is common, and I think we're going to find it's much commoner as we go on, as we're better at looking for it, and we have an older, an ageing population. Bone scintigraphy, I hope I've managed to convince you, has a really key role to play in the diagnostic workup of these patients, with cardiac uptake on DPD being indicative of cardiac amyloidosis, but no cardiac uptake on DPD, not necessarily meaning the patient doesn't have AL, cardiac amyloid, which is very, very important to realise, and that cardiac uptake on DPD does not necessarily mean TTR. You still need to exclude AL, cardiac amyloidosis, so you should always be sending, when you see these patients in clinic, serum and urine immunofixation. Now, not all labs routinely immunofix, so you need to request that, as well as serum-free light chains, and if there's a hint of a plasma cell dyscrasia, you need to be liaising with your haematology colleagues as well. SAP scintigraphy is excellent for extracardiac amyloid deposition, and indeed can be useful in monitoring response to therapies. However, just to remind you, there is no cardiac uptake seen with SAP scintigraphy. The molecule is simply too big to cross into the myocardium, and unfortunately patterns of organ involvement can be suggestive of the type of amyloid, but really not diagnostic, as there is a lot of overlap. And then finally, there is this sort of emerging role of PET imaging, which seems to be particularly positive in patients with AL cardiac amyloid, and whether this correlates with outcome, which some of the early data seems to suggest, will prove very, very interesting. And I imagine we'll see a lot more data coming forward in due course.
Please comment below if you have any questions. If you found that interesting, please like and subscribe for more lectures. If you'd like to know more, follow the BNCS on Twitter and visit our website. Thank you.